I will now talk about MSF Tanzanian MOH response to a malaria outbreak in the refugee camp of Nduta in Tanzania. It's not an operational research, but more a case report that includes vector control. This camp, the Nduta refugee camp, was opened in 2015 to shelter Burundian refugees fleeing from civil conflict in their country. MSF provides with other actors medical services in the camp since 2017. The population number fluctuated a bit, but is currently stable since few years, around 65-70,000 people. The camp is in a Tanzanian district where malaria endemicity is very high and where the transmission occurs all year long. It's also located in a humid zone and surrounded by swamp and rice field, providing perfect place for mosquitoes. Since the opening of the camp, malaria is an important health problem. First, linked with the refugee immunity profile, as many of them came from non-malaria area in Burundi, and also by the demographic profile of the camp population with a huge proportion of children. As being also the low sanitation of the camp was also providing excellent place for mosquitoes to breed, and insecticide resistance was compromising the few mosquito nets available. Despite serious improvement in sanitation and net distribution, malaria remained a serious issue. Many efforts were done in vector control. IRS, for example, was introduced in 2019 by the Ministry of Health. And as we can see on the graph below, that represents the number of cases since 2018, the first introduction of IRS was extremely successful during 6, 7, 8 months. However, in 2020, the population of another camp was merged with the Nduta population, and because they were settled in plastic sheeting tents, they were not included in the next IRS campaign, and that represents approximately 1/3 of the camp population. So it's why we can see that the next IRS campaign were also successful, but during a shorter time and with a bit less of impact. Also, in 2021, UNHCR did a net distribution, but the model distributed was compromised by insecticide resistance. The result was, despite serious effort in malaria control, a transmission persisting in the camp and progressively increasing until November 2023. In 2023, the number of malaria cases by month was around 7,000 to 8,000 on a population of 70,000 people. So we propose a package of activity that was implemented with the support of the Tanzanian Ministry of Health. So we organize a detect and treat campaign that reach and treat approximately 36,000 people from July to October 2023. Then in November, we run a mass distribution of nets and an IRS campaign that included all the shelter of the camp. The results were immediately visible after the vector control phase, and the number of malaria cases decreased to less than 800 by month despite the rainy season early 2024. IRS campaigns were maintained every 6 months then, and malaria cases remain under control until now. So of course, with this good result, I want to advocate for my specialty, that is vector control, and to remind that with a sufficient coverage to generate a community effect and perform regularly, vector control is a very powerful tool to get malaria under control. And finally, a last word also about what I call an umbrella effect. Because malaria trend is currently very low in the camp, there is less need of budget related to malaria, like tests and drugs. And in the current context of fund reduction, it is clearly helping other actors too to maintain their program, like antenatal care or primary health care. I thank you for your attention, and if you have any questions, please don't hesitate.